Here we go. Well, good morning, everyone. Thanks for joining us from your living rooms. Very good to just see everybody, see the names and the faces as we convene this session this morning. This year is important for the Institute of Medicine because the State of the Health of Chicago convening this year will be done virtually, and a lot of the work that you will hear about today and the impetus for it was a result of State of the Health of Chicago convenings sponsored by the Institute of Medicine. It's an activity we do every other year, and this is the year that we'll be doing it again virtually in the fall. So we're excited about this work, welcoming you to this second focus group. This work is as a part of a body of work undertaken by the Institute to do a feasibility study on the possibility of a well-being trust for metropolitan Chicago. I want to start out and thank our funders for this work. This effort, next slide, has been funded by a grant from the Portis Foundation, the Michael Reese Research and Education Foundation, and this session today is supported by the Washington Square Foundation. I want to thank all of the funders for supporting this work, this effort, and this convening today. I want to thank the Rush University Medical Center and Terrence for their support with the technological features of our virtual meeting. A couple of housekeeping concerns. Non-speakers, you will be muted. However, during the breakout sessions, all participants will be able to speak. We ask that you physically raise your hand or raise your hand electronically at the bottom of the panel and unmute yourself in the upper right-hand corner of your personal video. I think all of us are getting much better at this today. I'm probably the lowest on the totem pole here in terms of the technology piece, but we got Terrence here to help us. Just reach out, send a private note to him if you have an issue. He will work to troubleshoot with you to finish. Let's take a look at the agenda for this morning. Dr. Elizabeth Carlson is the PI of this grant for the Institute. Dr. Carlson will talk to us about how we got to this point. Our guest, Dr. Soma Stout, Vice President of the Institute for Healthcare Improvement and Executive Lead of National Effort 100 Million Healthier Lives, will be our keynote at 9:30 to talk about building the trust on the journey to creating well-being well-being trusts. And then at 10 o'clock, we'll have our orientation for our breakout groups. We'll break out in about 2 to 3 groups. We'll reconvene, and we hope to wrap up promptly by noon. Next slide. Just a few notes about the history of the Institute of Medicine and kind of how we're getting to the trust piece in the work. You'll note that the Institute is 105 years old. It was founded in 1915 by 15 physicians wanting to improve care in the city of Chicago. Over the years, the Institute has advocated at times when big change and big moves were necessary to improve the care for the people of the city and the county, and when there was a need to bring people together around sort of key big issues that impacted large parts of the population. In terms of standardizing kind of approaches to autopsy, advocating for broader emergency public ambulance services, working to ensure that hospitals would allow African-American physicians to come on staff, and then launching the Chicago Patient Safety Forum, which is now freestanding and really helped to sort of ignite the dialogue around patient safety in institutions of care. The SOHOC the first one was done in 2012. In 2017, we identified kind of 8 key topics that included social determinants of health, opioid epidemic, mental health, and then work around community health workers. Next slide, please. In 2017, we began to look at more ways to engage kind of more significantly on these issues. And the findings of SOHOC 2017 really laid the groundwork for a strategic plan that included research into the development of the trust concept. The Portis Michael Reese grant was awarded in 2019 that allowed us to staff up to begin to explore, identify themes and viable approaches for this work. So here we are today. Next slide. You're going to hear from Dr. Carlson next. She's a chair of this effort, and her co-chairs, Dr. Patel and Denise Giambalvo, are also involved here. But I'll let her walk you through some of the work and kind of introduce to you kind of where we are now and how we'll get there. As a part of this work and our SOHOC work, the Institute is launching a virtual series where we're doing our job of convening in these complex times, although albeit virtually, to talk about kind of where we are with COVID-19, wealth disparities, health disparities, all the drivers of gaps in healthcare for populations that we all care about. On October 8th, we'll kick off that series. On October 23rd, we'll have the grand convening. And at that time, you'll have a report out on kind of the progress of this work that brings together the results from focus groups 1 and 2, and also the research that we've done into the background for the trust. So today, you're really an important informant, if you will, and we really look forward to having you participate today. So with that, I'm going to turn it over to Liz. Thank you.
Good morning. Thank you. Oops, sorry. The Institute of Medicine has and continues to have a long history. Oops, sorry. IOMC has and continues to have a long history of interest in and commitment to health disparities and inequities that exist in Chicagoland. The Portis and Michael Reese Foundations have demonstrated a similar interest, and we are grateful to them for providing IOMC with a grant to support our efforts to investigate ways forward through a management and implementation committee. I would like to recognize and thank my co-chairs and members of the management implementation subcommittees who did all the work that you will see here today. So why a Wellbeing Trust Initiative? Whoops, and why now? The pandemic has exposed the disparities between groups related to social determinants of health. Although IOMC began looking into Wellbeing Trust initiatives in 2019, as the work continued, we believe that opportunities may exist by the establishment of a Wellbeing Trust that may assist in addressing these gaps and overlaps. We believe a trust can assist in addressing the gaps and overlaps. A trust can engender a shared purpose across its members. Trusts vary in focus and organizational structure, thus making them customized to the area. The role of a trust is to coordinate and integrate services to reduce duplication and increase efficiency. To do this, a trust provides infrastructure and technological resources, as well as value-added services such as staff training, tech support for social media and data use, and operational supports. How we came to this recommendation will be described. Due to IOMC's recognized role as a neutral broker or convener, we believe that we were ideally suited to serve as a catalyst for this work. Beginning about 2 years ago, we began to examine the ways that social determinants of health are addressed in various communities. To this end, we reviewed what others have proposed and implemented nationwide to address these issues in a collaborative and organized manner. We knew that there were and are both overlapping and gaps within and between current efforts. The goal was to examine opportunities to improve current efforts that would, if implemented, make a difference in the well-being of individuals, families, and communities. In 2017, The IOMC State of Health of Chicago focused on how social determinants of health are addressed in various communities. We reviewed what others are doing nationally and locally to address these issues in a collaborative manner with the goal of determining opportunities to improve current efforts. We invited Dr. Soma Stout, our speaker today, a national expert and executive lead in 100 million healthier lives, to gain a better understanding of best collaborative practices, innovations in approaches, and the importance and value of listening to communities active in addressing these issues. In July 2018, the IOMC board supported the development of a Metropolitan Chicago Community Wellbeing Trust, facilitated by the IOMC. To further our common knowledge of well-being trusts, IOMC invited John Auerbach, who headed the Massachusetts Wellbeing Trust Fund, to present at the annual meeting. Subsequently, IOMC reaffirmed and announced its plans and commitment to this work. In October 2019, we received a one-year grant from Portis and Michael Reese Foundations to conceptualize and catalyze the formation of a well-being trust, to develop the governance of the trust, formalize the founding trust membership, and develop a plan and budget for the implementation of the trust. We established the Management and Implementation Committee and 4 subcommittees to gather information. We were purposeful in ensuring a broad and comprehensive membership of recognized leaders to inform our work, sought out other national and regional experts, and engaged the help of local university students in this work as interns. While work is ongoing, we have developed a compendium of rich resources and reports. These can be shared and will be used towards developing future steps. Suffice it to say, we have tried to be as diligent and thoughtful as possible. Each subcommittee used this detailed qualitative approach to guide its work. The National Trust Subcommittee reviewed several of the growing number of well-being trusts across the nation. This included a particularly detailed analysis of 4 widely regarded trusts: the Michigan Health Improvement Alliance, MIHIA, Well-Being Trust, California, Massachusetts Prevention and Wellness Trust, and the Colorado Trust and Colorado Trust Healthy Communities Initiative. Reviewers also considered their applicability to Chicago. Recently, we interviewed a leader of the Milwaukee Healthcare Partnership and Milwaukee Anchor Collaborative, and learned that there are definite lessons to apply to Chicago. One interesting observation is that most trusts are at the state and regional level, with few at the metropolitan level, which would make a trust focused on metropolitan Chicago. And we're defining metropolitan Chicago as Cook County and the 6 collar counties. So it would make a trust focused on that area different and somewhat unique from other well-being trusts. Obviously, funding is needed for a Chicagoland trust, and how that will be structured and what the sources of funding will be is yet to be determined. Wait a minute, sorry. Sorry. While there is significant variation among well-being trusts and alliances, the most promising ones share these key characteristics, which are therefore likely to be important success factors. I'm sure they will be touched on further by our guest speaker today. To date, the local coalition subcommittee has been able to identify over 40 alliances in metropolitan Chicago addressing aspects of social determinants of health, equity, and drivers of well-being. Our key observations to date are: there's a significant variation in size and scope of activities of local coalitions and community groups. Some are single issue focused, while others are complex, multi-dimensional interventions and organizational partnerships. We are led to conclude through a review of publicly accessible websites and an online survey of coalitions that we conducted that several organizations have overlapping focus areas while gaps in coverage of need persist. There is a lack of or few broad multi-sector coalitions, and many organizations struggle for sustained funding of programs over time. We believe that since resources are tight and likely to remain so for some time, the ability to demonstrate outcomes achieved with the resources used has and will become even more important, if not critical. There are 8 participants, 3 coalition organizers and 3 data. So what did we learn from our, wait a minute here, I'm sorry. Okay, I'm sorry. I missed a slide. This is what we did for our in-depth review of each subcommittee took this approach to be systematic and thorough. This is what we've observed. I mentioned that these are common features of success. These are the coalitions that we've learned about to date within the Chicagoland area. Now, the Coalitions and Alliances Focus Group Report. This was from our focus group 2 weeks ago, September 4th. There were 8 participants, 3 coalition organizers and 3 data gatherers and analysts, a moderator, scribe, and observer who contributed to the focus group. Coalitions not able to be at the table informs us of the reality that activities and availability may be due to reduced funding, shifted attention, and or dissolving coalition work. Calls were made and emails sent to engage them. And those of us who made those calls and sent emails found that many coalitions no longer had telephone numbers, active telephone numbers, and that we received no replies to our emails. Together, the focus group prioritized the following: to ensure funding for data infrastructure across community-based organizations just beyond direct services, move from process measures to standardized outcomes, qualitative and quantitative. Ensure that the right people are at the table, provide needed technical support, which would include social media supports to help coalitions and alliances better get their information out, to these coalitions and community organizations that struggle with a limited bandwidth. Racial equity should be the focus of all things and build on successes. And we need to meet individual needs through living wage, safe housing, and access to reliable internet. We also have a metrics and analytics and metrics subcommittee, so we know how we know our impact. How will we measure that? So they're looking at data and measures relevant to social determinants of health from public and private sources, both locally and nationally. The goal is to develop a framework for potential shared, short, intermediate, and long-term outcome measures and indices that combines existing publicly available measures with novel approaches for real-time monitoring and that are relevant to local coalitions. The intent of this effort is to align with outcomes that coalitions are trying to achieve and help identify what is working within and across committees, organizations. It would support these quantitative efforts would support important qualitative assessments. The Analytics Subcommittee has canvassed available sources of data, starting with lists of indices recommended by Wellbeing in the Nation through a comprehensive Delphi process and tied to the Healthy People 2030, as well as all measures featured in the Chicago Health Atlas. With the help of student volunteers, they've reviewed what data is available at zip code or census tract level and what data is current and accessible enough to be available. Some examples of good sources, albeit mostly lagging indicators, are zip code level or census tract data on proximity to grocery stores, walkability index, poverty and income inequality on insurance rates, air quality, green space, racial segregation, and small area life expectancy. Multi-indices of social risk that combine many of the above factors, namely the Social Vulnerability Index and the Area Deprivation Index. We are also looking at efforts around the country for the example of novel approaches to get near real-time data, potential sources of data that the Wellbeing Trust could use to develop very current and very local monitoring are things such as fielding a community panel survey to monitor constructs such as overall well-being, financial well-being, and equity. For example, Cantrell's ladder. Another idea, using credit agency resources for near-time zip code level monitoring of financial and housing stability, employment, and criminal justice. One example of that is the TransUnion Social Determinants of Health Risk Attributes Scale. Another is using aggregated clinical data across health systems to monitor chronic conditions and preventive care, such as using Capricorn. And the last idea at this time is using aggregated data from community service providers through sources such as NowPow or other similar systems. The subcommittee has also scored data sources on key criteria to identify the most important and actionable, providing a consistent and reproducible approach to data sources. Lastly, we have a glossary subcommittee, and this is to ensure that we all have the same understanding of commonly used terms and that we use a common language. So prior to our keynote speaker and subsequent focus groups, a brief recap is in order. To date, the subcommittees and Management Implementation Committee reviewed a number of trusts and analyzed them based on how well their features would work in Cook and the 6 collar counties. A trust can engender a shared purpose across its members. Trusts vary in focus and organizational structure. The role of a trust is to coordinate and integrate services to reduce duplication and increase efficiency. To do this, a trust provides infrastructure and technological resources, as well as value-added services such as staff training, tech support for social media and data use, and operations. Today, we're hosting the second of our 2 focus groups. A brief summary of the initial analysis of focus groups 1 was presented earlier. A more in-depth analysis and synthesis of data from both focus groups on the 4th and today will occur and be presented at State of Health of Chicago on October 23. Subsequently, we will disseminate the findings broadly. We invite you to attend SOHOC and join in this exciting undertaking. Thank you. And now I have the privilege of introducing our keynote speaker. Our keynote speaker is Dr. Soma Stout. We're very pleased to have her as our speaker. Dr. Stout is a vice president at the Institute for Healthcare Improvement and the executive lead of 100 Million Healthier Lives, which brings together 1,800 plus partners in 30 plus countries to achieve transformation in health, well-being, and equity with an audacious aim: 1 million people thriving globally by 2020. She has worked as a primary care internist and pediatrician in the safety net and a global public health practitioner for over 10 years. She also serves as the co-principal innovator for the SCALE initiative, which supports communities around the country to accelerate their journey towards a culture of health through the development of community of solutions skills, behaviors, and systems. She's currently on the faculty on the Cambridge Health Alliance and Harvard Medical School. Let me stop my sharing.
Good morning, everyone, and thank you so much, Elizabeth, for your kind welcome. I have to admit, in full disclosure, that was my job a year ago.
Oh!
As we've gotten to 2020 and the natural close of 100 million, which has, it's been a real privilege, I have to say, really the privilege of my life to have led that initiative and to see change makers around the world create transformational change that improved outcomes. I think the last time we counted, over 740 million lives had been improved through, and really that was not what we did. That was really what people in communities did. And as they did it, we learned from them what it took to improve health, well-being, and equity. And out of that, as we began to say, what happens past 2020, we said, well, what would make these things that we're learning is what's needed a new norm. How do we go about doing that so that it becomes not a campaign or an initiative, but a sustained change that's owned by many? So my last 5 months as vice president at the end of 2019 at IHI, my only job was to begin to create an organization that could help to really think about those system changes so that IHI could continue its work around capacity building and health system transformation related to 100 million, even as we began thinking about how we shift the national context and popularize measures like the Well-Being in the Nation measures, our first multi-sector measures of population and community health. There is a whole network now that's formed of hundreds of organizations that have said, wait a minute, we finally have measures that we believe in across sectors. Let's build a collaboration that can actually shift the system. And to do that, we need to not just move what we measure, we need to change our policies and systems, our investments, and we need to think about how we work together differently across sectors and with an eye to equity. And so I have the great privilege now of leading what's emerged out of that process is the Well-Being in the Nation Network and an organization called Well-Being and Equity in the World that serves as a catalyst in that work.
How do I
and I remain faculty at IHI, of course. I'm always part of the family. I feel like I'm really bad at leaving organizations. Like I somehow remain connected with them because there's so much, each one of them influence who we become. I think that's the story of all of our journeys as people. Our what we do and how we get there are influenced by everyone who touches us throughout our life course. That's why we know, for instance, that exposure to toxic stress in early childhood in 0 to 5 or minus to 5 can have a 40-fold higher risk of developing of someone developing heart disease and diabetes. And I remember being with many of you in the context of your own journey as you were thinking about this and showing how these maps that we see across the country that show the relationship between the health and well-being of people, places, and the systems driving inequities are related. That exposure to toxic stress that comes from economic hardship on the left-hand side looks a lot like the map of childhood obesity, and ACEs scores looks at that. If you fast forward 30 years, that map on the right-hand side will be the map of premature diabetes. And then if you fast forward that another 10 years, that'll be your high-risk, high-cost patients. And then another 10 years or so, and it's a map of premature mortality with a loss of life expectancy. And that sense of, across all of our efforts in the healthcare system, many of which were beginning to have some real traction, what we had functionally done, if we weren't really understanding place, if we weren't really thinking about how we enable multi-sector collaboration to affect those social determinants and root causes that are related to place, that we were functionally organizing ourselves as the best organized bucket brigade putting out a fire, even as there was a tanker full of gasoline at the same time. I became really interested in what that tanker full of gasoline was, and it turns and why these maps look the same across the country. One thing that we've learned over and over again at IHI is that every system is perfectly designed to obtain the results that it gets. And so when we see that these maps look the same across the country, that's an indicator that there's a system in place that's driving those inequities. While I gave you in this story a map of chronic disease and the development of that, if I had replaced that right-hand map with incarceration and the incarceration pipeline, and I would suggest to you other COVID cases, it would look pretty identical. And I hope to make that case to you today and invite you to think about how we then shift the system to truly transform those outcomes, and including the way we use our money differently as a way to rebuild and restore life back into people and to communities. Of course, that system of and the reason these maps look the same, what I learned was the systems in place have to do with our legacies of structural racism and other inequities, by which we literally drew lines around communities of color in the early 1900s. That then led to homeowners association and banks not giving loans, either mortgage loans or bank loans to people living in those places. And so when businesses couldn't get loans, that meant you didn't have jobs. And when people couldn't get home loans, think about all like how taxes are related to property value. If you couldn't build in those places, what that meant was that these places don't actually have enough of a tax base to have good schools, great healthy streets, parks, all a safe environment, all the things that we know are crucial to the determinants of health. And that while I describe one policy, if you were to read this incredible report from the Prevention Institute, which I highly encourage you to read, it really goes into housing, transportation, of all of these things piled up together with a series of policies that have led to this system. That I showed you before. This is of course a map of Chicago, and you all have seen across the country maps of how social vulnerability, this is a social vulnerability index in Chicago, and this of course relates to where there are high levels of racial and ethnic minorities, and these are the risk scores by zip code in terms of COVID deaths. And what the green dots are the COVID deaths. And you can see this pattern reproducibly show up over and over again. COVID, in fact, if nothing else, has been a societal stress test that has revealed the underlying inequities that were already there in the system and are showing up in this current moment in time. And that really brings us back to how do we interrupt that cycle of that tanker of gasoline that's going into the fire? Or do we just keep chasing what we need to do to get, we of course need to do the things we need to do to keep help people once they're sick, but how can we stop this production system of illness? And that, of course, in the context of COVID, you've seen across the country that communities with high and low concentrations of Black, those with high concentrations of people who are Black have had far worse outcomes, along with Latinx and Native populations. And those relate to the underlying conditions of the place, like clean water. In Native reservations, if you don't have access to water or you're in dense housing situations, you're much more likely to spread COVID. But it also relates to things like environmental pollution from factories and what gets located, highways that get located in communities of color because the land was cheap. And as a result of that exposure to chronic environmental pollution that affects literally how we breathe. And then the underlying prevalence of chronic illness, so that these maps of premature diabetes suddenly translate, of course, to higher death rates from COVID. And we can see how these all come together. Of course, this pandemic has been a pandemic overlying an endemic that has shifted people in terms of their mental health and physical health together, and in terms of their economic insecurity and social connection. And what we see, of course, is that today less than half of Black adults have a job. You see this blue line, this is Latinx people, Hispanic people. They had the highest rate of employment prior to COVID nationally, and now they're second only to Blacks in terms of unemployment. When you look at February, over half of those who were employed say that they lost a job, hours, or income. And really, when you look at that, though, everybody didn't lose those hours equally. If your household income was greater than 90,000 a year, you lost only 30-something% of people lost their jobs. That one goes up to almost 2/3 of people if your household income is less than 40,000 or even 40 to 90,000. And when you look at who doesn't have the underlying wealth to ride out a pandemic, that is, of course, there's a huge racial wealth gap in place that we need to take into account. Most Black families have $8 of wealth compared to thousands for the average white family. And I think it's one of these things where if we don't begin to understand the outlines of that system, we don't begin to understand how we can deal with it. No, we could have a conversation all day about what's creating this, who has access to a sense of community and belonging, mask wearing, basic needs. But what I'll tell you is that those maps look the same. This is COVID cases, child poverty, COVID unemployment, and health status. This happens to be the lower third of Texas. We're working in Rhode Island. The maps look exactly the same. And so it really, all of this at the end of the day gets back to what I think of as the two escalators that we have to deal with. One is on the right-hand side. Imagine that everybody's trying to get up to the top, but the right-hand escalator is going up and the left-hand escalator is going down. That if you have privilege, it's as if you're on that right-hand escalator. And what that means is that your personal effort matters. If we run up that escalator, or we can help people up that escalator, they're going to get up to the top faster. But if anything happens where bad luck happens, people get sick, they get tired of running, they need to stop to help someone behind them who may have tripped, and they stop running, they're going to keep going up that escalator up to the top. They're going to make it. Versus if you don't have privilege, and that can be, of course, from a number of factors, from race, income, place, etc., then you're you're trying to run up an escalator that's going down. Now, your personal effort matters, and for some people, they're going to be able to run up fast enough to make it up to the top. But it's going to have a huge wear and tear on them. We're increasingly learning of higher levels of hypertension, et cetera. And of course, we all know the difference in Black women's mortality, even among those who are college educated, that we know exists, continues to persist as disparities, really belying the idea that just getting up to the top is all that matters. But what we call that allostatic stress. But the other piece is that if for any reason you aren't able to run fast enough, you end up, something happens to you, like bad luck happens and you have to stop running, or or you get sick, or or twist an ankle, or someone behind you gets sick and you need to help them for a moment and you stop running, you're going to start sliding back down. And for me, that escalator is that same tanker of gasoline, that's pouring into the fire. When I think of so many of our efforts in healthcare and in other industries, we've come to expect these two escalators to be in place. And as a result of that, we, instead of assuring that everyone has the vital conditions, that escalator going up, that they need to thrive, instead, most of our efforts are from rescuing people before they've fallen off the edge of the escalator all the way, or in pulling or pushing people up the escalator as if they are the focus of intervention versus, and don't get me wrong, if you're about to fall off, it's really helpful to have that help. There's nothing wrong with helping people when they are in trouble. But if we're really being strategic and smart about it, we would do something to strategically reverse and work together across sectors to reverse the direction of the escalator. Because this isn't a healthcare alone problem. When people die 25 years early, it's the same people who end up dying prematurely and developing chronic disease that costs employers something. And it's the same people who are social services are trying to catch and burning out. It's why all of us start burning out as we're trying to catch people who are falling off that down escalator. And I think if we can begin to think about how we can see and name the issue for what it is, and then begin to say, how do we change the system? One of my favorite graphics, this one happens to be from FSG, but it's the 6 conditions of systems change. We say that you need to start by shifting our mental models. That's some of what we've been talking about today, to see the problem differently. We need to shift our relationships and connections and power dynamics. That's really how we relate to one another. And then we need to shift policies, practices, and resource flows. What we call that leading for outcomes and strategic systems change. The bottom is leading from within, the middle is leading together, and the top is sort of leading for outcomes and system change. So if we think about that, you all are here today because you've decided to do something about this. You've decided it's worth thinking about how we reverse the direction of that escalator and how resource flows might need to change in the form of a well-being trust. So I want to invite you to consider today that in addition to that, to really do that successfully, you'll also need to think about how you shift mental models, your minds and hearts, and how you shift relationships and power dynamics among you. And that it's really on this foundation that policies, practices, and resource flows in particular can shift. And so as we think about that, here are some opportunities for where that, I want to really commend you for starting this conversation and going on this journey, because shifting resource flows matters. If you can stop investing in silos, because everybody's trying to solve this problem separately. Public health is trying, and healthcare is trying, and businesses are trying, and social services are trying. Everyone's putting a lot of energy into being their best possible bucket brigade, rather than thinking about how we work together to shift that tanker of gasoline or to reverse the direction of the escalator. It turns out that we can usually do much more together than we can do alone. In Cincinnati, they discovered that, which had one of the worst infant mortality rates in the country in poor birth outcomes, worse than Costa Rica, which they weren't proud of. Cincinnati children said, wait a minute, this is in our shadows, but what's happening? They began the All Children Thrive initiative, which when they began that process, what they discovered was that there were over 1,500 groups working on infant mortality in Cincinnati, hundreds of them, but all working separately. And by they're agreeing all collectively to bring their efforts together to form teams that were made of dozens of organizations moving a key shift, that then they could begin to think about how they invested together into the key driver solutions and how they first coordinated their assets and processes along with the money to be able to find better outcomes. In order to do that, you need to find a way to measure value in a way that's meaningful across sectors. Because in reality, there's a wrong pocket problem. And that gets to number 3. So what can happen, say that I'm able to, we know, for instance, 60% of people, so 3/4 of people who are incarcerated are Black or brown, 60% of them have a mental health or addiction disorder. And they're the same people, especially those who are in jails, who are cycling between emergency rooms, social services, and jails. Adding mental health services to divert people. So for instance, instead of trying to get police to be social workers, actually embedding social workers and having social workers and community teams respond and divert people into mental health treatment is really great, because it reduces emergency room costs, it improves incarceration costs, and it really actually improves police costs. The issue with that, though, is the savings, the cost of doing it goes to the group that's providing it. In the case of Delaware that enacted this strategy in real time, in the context of COVID, that was the Substance Abuse and Mental Health Agency, but who's benefiting emergency rooms and prisons they're different groups. And so what can be really helpful, if you have a shared measurement, we're trying to prevent people from, we're diverting people who have mental health and addictions into treatment, as opposed to environments that create poorer well-being, like such as emergency rooms and prisons. Not conflating those two, just to be clear for this audience, but just recognizing that there are better places to actually receive that care. But what can happen is, if you can have a community well-being trust and you have a common measure that you're trying to improve outcomes for that population, then you can actually solve the wrong pocket problem with that well-being trust, and use the savings in a way that redistributes where things should go to actually help invest in that solution. We can fund long-term investments in community and civic infrastructure, as well as short and medium-term focused outcomes. And you can invest in building community capacity to address complex issues such as racial justice and equity. I am going to start with how not to do well-being trust, because we've seen a lot of these now across the country and seen where things fall apart. And typically where things fall apart is when people start with the money rather than the clear what or why that matters to communities. And that matters to the partners, but especially that matters and would improve outcomes for the community. They don't do well if you shortchange the work of relationship building and trust building across the multi-sector collaboration. We described in 100 million, what we learned was that communities that did this well underwent positive spirals of transformation, and that at each turn of the spiral, as they built their collaboration and trust and their ability to move outcomes that matter, they were able to gain the investment in resources and the willingness to share, because people could see that investing of resources into a common pool would lead to a real outcome. A third is shortchanging the work of building trust with communities. It can be very easy when you're coming in with the money to let that money be the power that leads. But actually, in the absence of trust, you don't actually get to hear what would actually make a difference, and you don't necessarily hear the stories or the enabling solutions that communities can provide that we usually can't access from the top. And if we don't have sort of clear parameters and processes to create equity and governance processes and outcomes, what can happen is these can quickly become places where we invest, the money drives the agenda, but then the right solutions aren't invested in, and then people lose faith in what that can accomplish. And finally, a lack of accountability mechanisms or ways of understanding multi-sector total return on investment, so that you really value the in that diversion example that I told you, you value the mental health and well-being that's created and have a way to measure and project that. You might have ways of looking at costs averted across sectors, so that you get a total return on investment that says, here's what's happening in terms of years of life gain, in terms of well-being improved, and costs averted across sectors rather than in only one. And that, if you can create those accountability mechanisms, then you can sustain your well-being trust, because it's built on things that really foster and support collaboration. I'm going to go into a couple of examples of groups that I think did well-being trust. They didn't start with this idea of a well-being trust at all. They started with trying to solve a problem. In Wyoming and Laramie County, they were trying to solve the problem of what they called homeless runaway youth. And they'd actually gotten some contributions to start to create a home for the youth, and then got a huge not in my backyard response from the community. So they didn't have any choice except to really regroup. And one of the people that the groups they regrouped with was the quote unquote homeless runaway youth themselves. And what the homeless runaway youth quote unquote said was, maybe this would be better if you stopped calling us homeless runaway youth, number one. Because that's not who we are, nor is it how we want to identify ourselves. And maybe that's harder for people in terms of who they want in their neighborhood. And so they were taken aback and said, well, who do you want to be known as? And they said, well, students. We want to be known as students because we're trying to stay in school. And that shift, they had to come up with something else that reflected the unaccompanied minors, or unaccompanied students became the new name of the initiative. And as they listened to the ideas of the students had this idea that, wait, half of us are already living with somebody we know, and we don't need a new building. We actually just need, it's just hard for those people to keep us for a long time because we cost a lot of money. We eat a lot because we're teenagers, and we outgrow our clothes. And if they could just have a stipend to keep us, then maybe we could just stay, and you could use the rest of the money to help us stay and actually get the teaching, get the educational supports. I didn't use those words, but supports to stay in school and do well in school. So they brought the youth together with the community as a whole, including health system, business, and other leaders. But a third of the room had been among the not in my backyard responders. And instead they built relationships with the youth. The community listened to the stories of the youth, how they got there and why they got there, but also their ideas for what would help. And as they did that, they shifted who they saw these youth were, not as homeless runaway youth or even as unaccompanied students, but as the future leaders of the community. And within that next 6 months, they all co-invested together in the idea that the youth had to have these stipends. Within that next 6 months, that half of the youth who were housed. And then as they realized, they put the money into educational supports. There are double-digit improvements in graduation rates, and that really built their motivation to make sure the rest of the youth also had that support. Those other half of the youth didn't have a place, didn't have people, and so instead they actually built that house in the first place so that everybody had a way to come in out of the cold. And I think if you think about those spirals, and by the time they built that house, there are 65 organizations co-contributing into the fund that keeps youth housed in school, learning and growing as community leaders. It grew naturally out of a need that they had. In Wisconsin, over 100 businesses came together to address and think about how they could eat healthier. They created an insurance plan together that as they helped employees in machine and manufacturing have easy, low-cost options for eating healthy. and an exercising, did employer engagement work. As they did the HRAs, they found reproducibly that their health risk scores went down, and they had significant savings. And they instead of keeping the money to the insurance company, they shared the money to build that multi-sector community well-being trust that then built a community center and other assets based in the schools that funded a whole community transformation trust strategy that led to the elimination of hunger in the schools, as well as a number of outcomes. This community is now built a whole system to interrupt the school to prison pipeline, and within 48 hours of COVID hitting, had figured out how to create digital inclusion for every student from 4th grade to 12th grade to be able to continue. Their well-being trust, their hardest work is figuring out how to spend all the money in their well-being trust, because the building of trust, the achievement of real results has led to people continuously putting so many assets into the pot that they've rarely needed to use the money itself. So the money has continued to be part of how they scale and replicate and really continue to grow their programs. And the Point Initiative in Wisconsin brought over 100 health systems, businesses, actually Oshkosh, U.S. Ventures, and others together to co-invest, along with all the regional philanthropy, to co-invest in addressing poverty together. They'd all been trying to do something different, but like the story of Cincinnati, here there were over 100 organizations that were doing some different piece of it. They came together. Their first investment was in a learning collaborative to think about what they would be able to do and the role of employers in particular. And what they found was that they needed to do things that in their case, unemployment was low, 2.7%, but poverty, especially child poverty, was high at 40%. And by building collaborations together, they were able to create a series of initiatives that included putting in assets like lending quality improvement specialists out to community-based organizations like the Y and others, that were and social service organizations, building job connection programs. They actually had a huge issue about brain drain and didn't have the workforce. They created ban the box strategies so that those who were returning citizens could get access to the help that they needed. And by really investing and thinking differently about how they could be connectors, how they could build coordinated entry for addressing homelessness across the system, how they could really build a pipeline from citizens, from a life of incarceration to a life of citizenship, with the work of wealth that they needed to get there, they really transformed what they could do. So key principles to doing well-being trust well. 1, begin by building the trust and collaboration. Lead with that. Start with the why. What could we do together that we couldn't do alone? Build on existing multi-sector collaborations when you can. You have Healthy People Chicago, Healthy Chicago 2.0 as a place to build that I really want to call out. And now, of course, there's the COVID-19 to Healthy Chicago 2025. I think there's already a process in place that's defined a lot of the what's and some of the whys. How can your community well-being trust, instead of replicating that work and all of that work of collaboration building that's already happened, how can you leverage that instead to enable some of the solutions that have been suggested? And then I would be remiss if I didn't point out the Well-Being in the Nation measures as ways to really enable you to think about how you measure differently and use ROI differently. And think about, what it looks like in a way that creates equity for the people who are affected. I'll just end with this quote, that abundance doesn't happen automatically. It's created when we have the sense to choose community, to come together to celebrate and share a common store. That whether the scarce resource is money or love or power or words, the true law of life is that we generate more of whatever seems scarce by trusting its supply and passing it around. Authentic abundance doesn't lie in secured stockpiles of food or cash or influence or affection, but in belonging to a community where we can give those goods to others who need them and receive them from others when we're in need. And so I invite you today to think, Where is the abundance in Chicago? Where is there already evidence of multi-sector collaboration that you can help enable? How can you become part of that team and really use your well-being trust to build trust and to build well-being? Thank you so much for having me with you.